Antimicrobial stewardship. Um, Globally, this is the rate antibiotic resistance. A failure to address the problem of antibiotic resistance could result in 10 million deaths by 2050 if not controlled, costing around 66 trillion of the healthcare sector. So this is the issue we are facing if not addressed currently. So antibiotic policy. The annual antibiogram should be prepared by the microbiology department. So and antibiotic susceptibility profile may be analyzed regularly, and common resistance pattern of the bacterial isolates to be reported and discussed in the hospital infection control meetings. This policy should be prepared in consultation with all the respective clinical departments. So what is antibiogram? Here you can see uh, a sample patient sample is sent to the lab for culturing and testing. Sample is cultured and antibiotic discs are added. After 24 to 48 hours, zones of inhibition will come into play. So according to that, you can understand which antibiotic will act on these microorganisms. So a standardized table with the label of results such as susceptible, dose dependent, intermediate, or resistant classification of microbes and what antibiotics should be used in these cases. So that's the antibiogram. Antibiotic policy principles. First, the data is analyzed on a quarterly basis as per the hospital records. In that, etiological agents according to the site of infection, age groups, patient location, is it the OPD patient or a inpatient? Antibiogram data again according to the site of infection, age groups, patient, OP patient or IP patient. Any resistant organism is confirmed and submitted to the further characterization at the National Centers of Disease Control. Okay, so these are the data which has to be analyzed on a quarterly basis and has to be communicated. Standard treatment guidelines as per age is there for community acquired infections and healthcare associated infection. In older children, bloodstream infection, meningitis, UTI, pneumonia, any GI infections, conjunctivitis, etc. These should be special treatment guidelines are mentioned for these diseases. In neonates, when it comes to neonates, sepsis, meningitis, treatment guidelines are mentioned. According to that, that has to be followed. Infants and small children, meningitis, sepsis, and pneumonia, standard treatment guidelines given should be followed. Classification of antimicrobials into first line, second line, and reserve group of drug. And reserve group of drug should be used only and when it is absolutely necessary. And first line and second line should be used accordingly to the make sure that narrow spectrum antibiotics is used as much as possible. And yeah, that's it. And prescription auditing. It is a review of surveillance data generated from the antibiograms and prescription auditing to check that doctors are not prescribing the high line of reserve and group of drugs for treating small infections, which will be treated with first line antibiotics, etc. To check that the doctors are not misusing the use of antibiotics for their treatment. And also the pharmacy officials will be checked according to the prescription auditing. Next is education and training for all infection control activities in collaboration with hospital infection control committee. So training the staff about what is the antibiotic resistance that the world is facing now, how to counteract it. Those will be provided here. Measures to control the spread of antibiotic resistance. It's a multidisciplinary approach and with the use of local antibiogram which is provided. And each use of an antibiotic should be justifiable based on the clinical diagnosis. And before initiating any antibiotic treatment, appropriate specimen of bacteriological examination report should be submitted. And according to that report only, antibiotic should be prescribed. And also you have to check the patient's tolerance, sensitivity pattern, cost, and as much as possible narrow spectrum antibiotic should be used with appropriate dosage and duration of antibiotic therapy. Make sure for long-term care, antibiotics are not used. It should be always short-term care. And cyclical rotation of antibiotics should be done within the class. There are around 8 classes of antibiotics. Do not jump from one class to another if you want to change the drug. Within one class, there are 4 to 5 examples of antibiotics coming in the same class. You have to interchange those antibiotics within the class, but do not jump the class. The standard and contact precautions, including general precautions and specific precautions, and recurrent adherence to the hand hygiene, practicing 5 moments before and after patient contact and after each procedures, use of personal protective equipment at every level while handling antibiotic resistant diseases should be put into place. Methicillin resistant Staphylococcus aureus, MRSA. So it is MRSA strains are resistant to penicillin, any kind of penicillin or methicillin, and they are sensitive only to vancomycin and teicoplanin. And these are highly transmissible diseases. Even across the hospitals, they can be transmitted. Control measures. What you have to do here is screening of MRSA carriage at the entry level. Even the OPD patient and IP patient, screening should be sent for this particular strain. Standard and contact precautions should be put into place while dealing with any carrier patients or infected patients. Isolation of MRSA patients. Do not mix MRSA patients with other patients. Cohort the MRSA patients together. That's fine. Treatment of infected patients with vancomycin or teicoplanin. Environmental cleaning is recommended post-discharge and during the treatment also. And education and training of the staff on how to handle the MRSA cases. Vancomycin resistant Enterococcus. It is difficult to treat because of the intrinsic resistance to many antimicrobial diseases, agents. Control measures are judicious use of antibiotics, and what you have to justify the use of antibiotics in VRE case. Education of healthcare workers. Hospital infection control practices should be scrutinized. Equipment and environmental cleaning should be done on regular basis, and do not use the same equipment used for procedures on VRE patients and other patients. Don't mix those equipments. Single-use equipments for patient care is recommended. Do not use these equipments on other patients. Isolation, again, cohort the patient or isolate the patient, but do not keep them with other patients. Use of personal protective equipments and regular surveillance of such cases. Multi-drug resistant gram-negative bacteria. Screening of the patients in high-risk units on broad, when a patient is in high-risk unit, when the patient is on broad-spectrum antibiotic, and they have been in the hospital for a long time, severely ill patient, suffering from chronic diseases, and they have impaired functional status, and presence of any invasive medical devices on a long term. So in these patients, screening has to be done for MDRGN. Screen the swab from multiple sites. Do not just depend on one site. From multiple sites, take the swab and send it for culture analysis. Follow stringent hand hygiene, contact precaution, isolation clinic, and dedicated patient equipment and judicious use of antibiotics. In healthcare facilities, what is happening are the antibiotic usage is high in healthcare facilities. You can't help it. And there is an unexplained variation between the hospitals in use of certain antibiotics, particularly the broad spectrum antibiotics. Proper explanation is not given why they are prescribing so much of broad spectrum antibiotics to all patients. And current and the future healthcare facility patients will suffer because of this attitude. So there is a need for more expensive and broader spectrum antibiotics to treat the infection in the future. And there is a need to isolate colonized patients with resistant organism in order to minimize the cross infection. So these are the problems we are facing in the healthcare facilities due to antibiotic resistance. In community, what is happening? Community antibiotic use is also very high. If you go to a pharmacy store and you ask for an antibiotic, they will most likely do not ask for prescription. They will directly sell you the antibiotic drugs. So because of this, in community acquired infection and community acquired multi-drug resistant antibiotic infection is also very prevalent. So this is what we are facing as of now. Antibiotic treatment for hospital. If 30% of antibiotics are reduced, prescription of antibiotics are reduced, then it could lead to 26% of fewer cases of deadly diarrheal infection in the future. This is the statistics. Antibiotic stewardship. And antibiotic stewardship is an effort to measure and improve how antibiotics are prescribed by the clinician and used by the patients. So while taking the stewardship, you make an effort to ensure that unnecessary prescription of antibiotics is not done by the clinician side, and unnecessary usage of antibiotics is not done by the patient side. It aims to optimize the antimicrobial use among patients in order to reduce antibiotic resistance, improve patient outcomes and safety, and ensure cost-effective therapy. At healthcare facility level, antibiotic stewardship involves implementing an antibiotic stewardship program so that everyone in the staff knows that such program has come into place, will be curious to know what it is, and awareness will be created for this, and thus antibiotic stewardship program will be put into practice. Continuous monitoring and analysis. Just putting in the program in words and forgetting about it is not done. You have to continuously monitor it, quarterly do the analysis of your prescription audit, etc. And any discrepancies should be communicated with the infection control committee. Requirements for antibiotic stewardship. First thing is enhancing infection prevention and control. That is the basic. Standard precautions, transmission-based precautions should be clearly put into place. Control the source of infection. Where, for example, if a patient is admitted with MRSA, they has to be isolated, and the healthcare workers dealing with that MRSA infected patient should properly follow the stringent hand hygiene practices and other contact-based precautions. Prescribing antibiotics when they are truly needed. Unnecessarily do not prescribe the antibiotics. Prescribing appropriate antibiotics with adequate doses. Even if there comes a time when you have to prescribe the antibiotic, it should be appropriate. Do not jump into a reserve group of antibiotics. Try to control the disease with narrow spectrum antibiotics or class 1 antibiotics. Using the shortest duration of antibiotics based on their resistance. Reassessing the treatment when culture results are available. If you are doing something wrong, when the culture results are available, you can reassess the treatment and restart the treatment accordingly. Supporting surveillance of any healthcare antimicrobial resistant diseases, hospital acquired diseases, by monitoring the antibiotic consumption. Regular surveillance should be done in both these cases. Educating the staff, retraining the staff, and reviewing the staff performance, etc. And supporting an interdisciplinary approach. It is a multidisciplinary approach. Everyone from different sectors of the healthcare facilities come together to promote the antibiotic stewardship. Thank you.